Certainly, Governor Baker, your leadership makes Massachusetts a model, I believe, for really all the other states. I'll come back to that question later, but I'm going to ask Commissioner Gottlieb. Scott, you have a big job in regulation, in trying to evaluate powerful drugs that can be harmful, but at the same time, they're beneficial, right? I heard you said when you came in as commissioner that you called on all of FDA, quote, to take more forceful steps on this issue of opioid crisis to stem it. So can you tell us a little bit what you're thinking?
I appreciate the opportunity to be here and speak to that. I will say at the outset that I think a problem that maybe was more fully within the scope of FDA to address in more totality has now grown in proportion, that it is, we still have an important role to play, but this is such a big problem that our impact alone isn't going to resolve this. I mean, we're going to need to work together with partners. And I'm not sure that I would have made that statement 10 or 15 years ago, but I think all of us didn't recognize the scope of how this problem was evolving when it was evolving. And I was at the agency 10 years ago when we contemplated this as well. I think the agency has multiple roles to play now. Obviously, we have a role to play with respect to better therapeutics. That includes abuse-deterrent formulations. We recently put out some policy related to how to develop generic versions of those drugs. That's going to pave the way to enabling us down the road to potentially clear the market of drugs that don't have abuse-deterrent formulations. That makes them less prone to manipulation and abuse, but doesn't make them less prone to addiction. We're currently rethinking the nomenclature of how we describe those drugs to make sure we're not sending the wrong signal to providers that an abuse-deterrent formulation is somehow less prone to addiction. We're looking at pathways to open up the development of non-addictive alternatives to opioids, and you heard some discussion of that on the last panel. We're going to be putting out some policy very soon related to trying to develop better and different medically assisted therapy. We have 2 treatments on the market that are agonists. Well, one's a full agonist, one's a partial agonist. We have 1 treatment that's an antagonist. But trying to get more variety in medically assisted therapy so that you can match the right treatment for the right patient is important. And also making sure that when patients present, they have the opportunity to select the treatment that fits what's going to be appropriate for them and aren't just put into a treatment because of where they present. We have to reevaluate the risk-benefit framework, and you talked about that in the report you made to us. We've taken that up as part of our mission. Early on, I was talking about that when I came to the agency. The mandate to look at risk not just in the labeled indication, but also in the illicit indication. This is not something that's outside of FDA's legal authority, but it's not something that FDA has traditionally considered. And for the first time, we recommended the withdrawal of a drug from the market, Opana ER, based purely on an assessment of the risk associated with the illicit use. And that was the first time the agency did that several months ago. To your point, Governor, we also have to look at the issue of what's coming in from overseas, particularly fentanyl. We recently announced that we're tripling the number of personnel that we have in the international mail facilities where a lot of these drugs come in from. They come in through the mail system, and we're stepping up the number of personnel we put in our cyber crimes unit to police the dark web. But even in tripling the number of FTEs that we have in the IMFs, and I have physically maxed out my space that I have available to my folks in the IMFs, and I'm now negotiating with Customs and Border Patrol, who have been excellent partners to us, to get more space to put more people in. Even in tripling our personnel, we went from 8 to 22. And we increased the number of packages we can pull from 10,000 to 40,000. I visited an IMF, and I without revealing too much, I examined some of the packages coming in that had the synthetic, the illegal fentanyl in them, and they all looked exactly the same and had exactly the same return address. And so I inquired why they didn't try to change up the packaging. And the answer was that once we start pulling packages from one location, then they just change the packaging at that point. But even if they experience a small percentage of loss, the volume that they're pushing through the mail system is so large that it's just the cost of doing business. So it would cost them more to try to disguise the packages than the cost of losing the packages, and I found that stunning. But I'll turn to where I think FDA has a particularly important role to play. And I think all of the things I talked about, I think are especially important. But I think we have a very unique role to play and more of a singular role to play in trying to address the new addiction crisis. And Nick, this gets down to trying to bring down total exposure to opioids. We know that there's some element of this that is just math. A certain percentage of patients who are exposed to opioids are going to become addicted. And most people who become addicted become medically addicted. And most people who become medically addicted started using an immediate release formulation of the drugs. 90% of all prescriptions, 190 prescriptions a year, are for immediate release formulations of the drugs, Vicodin, Percocet, and Oxy. And the question becomes, how do we reduce overall exposure? And there are two ways to do that. Reduce the number of prescriptions that are written and reduce the duration that the prescriptions are written for. And so we need to make sure that people, when doctors are prescribing these drugs, it's for an appropriate medical indication, and that the duration of use that the prescription is written for comports with the clinical circumstance for which the prescription was written in the first place. And we know that's not always happening. There are too many prescriptions being written, and there are too many 30-day prescriptions being written for tooth extractions. And so we think that there's a lot more that we can do through education and perhaps mandatory education as well as packaging to try to encourage more judicious prescribing of these drugs. And I'll give you one hypothetical of a world I would like to see. And I'm not sure it's something we can do with our current authorities, but it's something we can certainly try to skate towards. Envision a world where more of the immediate release formulation of the drugs are packaged in 3, 6, and 8-day packs. And in order to be a prescriber who wants to prescribe the 30-day prescription because you're a doctor who treats cancer patients who have metastatic cancer pain and require longer duration use, you might have to go through mandatory education. So you might see, in that kind of a world, more providers would default to the 2 or the 4 or the 6-day packs, much like doctors prescribe prednisone packs or a Z-pack of antibiotics, and a smaller cohort of the doctors would be writing for the longer duration of use, having had to go through extra hoops to be qualified to do that. For most indications, you think short-term surgical procedures, short-term dental procedures, a 4-day prescription is probably the appropriate prescription, and if you need longer duration of use in that kind of a clinical setting, you probably have an infection. We think that there's ways we can work with the provider societies to create expert guidelines that recommend what the appropriate duration of use should be for different clinical circumstances. We can incorporate those guidelines into labeling, and once those guidelines are part of labeling, we can use them as ways to help better control, regulate, help advise on what dispensing and prescribing should be in concert with the provider community, and health plans and others in the supply chain. So those are the kinds of ideas we're thinking about. We stood up a new opioid steering committee to try to think differently about how we use our authorities to address some of these things. But the one thing that's clear to me, and I'll close on this, is having been at the agency 10 years ago, more, 13 years ago, when we were contemplating what steps we needed to take to try to address this crisis, and we didn't get ahead of it. Nobody got ahead of it. And it's grown into the proportion that it is now. The type of action we need to take to finally get ahead of this crisis is going to be far more dramatic than what we would have had to do had we made certain decisions many years ago.
Thank you. Outstanding.